So welcome back to the next episode of Endoscopy Essentials. We continue with Mette Kalager from Oslo, Norway. We just stopped at the evidence discussion with randomized trials, and if you have watched the last episode, which of course we highly recommend, then we named quite a bit of the difficulties. Yeah. So Mette, today we want to talk about alternatives. We don't want to give up randomized trials.
No.
There may not be representative here and there. So how could we upgrade the rest of the evidence? We have retrospective studies, which are, if you want to do them well, are exceedingly difficult and time-consuming. Basically, in most hospitals, the quality of our routine data are, I want to remain polite, but really bad.
Yeah.
So what kind of observational studies? You were nicely distinguishing between experimental, randomized, and observational studies. Yeah. What's an ideal observational study? What database?
Okay, so an ideal observational study is a study that tries to mimic a randomized trial, where you can say something else if you want to find the effect of a treatment.
Mimic means with regard to data collection? And
mimic in terms of the patients in the different groups you want to compare, that you are establishing that you know very many factors about the patients, about the treatment system that may influence the outcome, which in this trial that we're set, or not the study we're doing now, is, let's say, survival.
So that means if you start, you think, if I would do a randomized trials, which parameters would I include?
Yeah.
And these parameters will be recorded in daily routine?
Yeah, even more so.
Even more, yeah.
Because for the randomized trial, you expect that a certain number of people, let's say 50, if you randomize them, they will be equal by chance. Because
even if you don't know all their parameters?
But for, let's say, if you want to study survival, you want to study survival of colorectal cancer, let's say, and you are comparing surgery with endoscopic removal of a small cancer, let's say, and you want to study survival, your hypothesis is that it should be about the same because you take out the tumor in both instances. One is minimally invasive, the other one is perhaps a little bit more invasive surgery. And then you need to think, what is influencing the outcome? It's not only the treatment, it's also factors associated with the patient. Could be age, probably age, sex maybe, socioeconomic status, smoking, maybe alcohol or substance abuse, and it could be other factors that we are not aware of. And these factors may differ in the two groups and influence the outcome, which is survival, and you need to have control of that. And there is no statistical method to help that you can use to make sure that you are taking away the potential differences between these two groups. And that's why we can't rely so much on the result we get when we do observational studies. And hear me using observational studies, not trial, because it's not really a trial, it's just observations.
Trial is more experimental studies.
In my head, it makes it easier to talk about it.
But then, if you want to know whether the factors are in a randomized study similar in the two groups, you know much less, if I understand you correctly, in the observational study. So you need to know more about the patients.
I think then it becomes the more you know of the factors you believe influences the outcome, which is survival in what we're talking about. The more you know, the more you can adjust for it. But then you need to know what you're supposed to adjust for. So what really matters? And sometimes we don't know. We don't really know what matters. And for life or death, when you die, it seems, and this is a hypothesis, now this is my hypothesis, is that, or not even a hypothesis, when we were doing a study on a randomized controlled trial on sigmoidoscopy screening, we compared the control group with the group that did not attend screening in the screening arm. Nothing, they had the same treatment for colorectal cancer mortality that was similar. And none of them had screening because no screening was going on. And of course, they are different in socioeconomic factors, and we collected socioeconomic factors. We collected all kinds of data on the patients regarding tumor size, regarding metastasis, all kinds of biological factors that we needed to know. And we did the best available statistical analysis comparing the two. Still, after all those corrections, the people who did not attend had a higher mortality than the control group. So there is an X factor.
Yeah.
I don't know what it is, and we have been discussing this over the years, and we always end up with more or less religious, is there a predestined? And now I'm saying it out loud. You might think I'm crazy, and I'm not. But there is something, so there is something that we cannot explain. And when we do observational studies, how does this play? And can we ever be sure that even though we have the best available data, that this doesn't play into factor when we interpret the comparison of surgery versus endoscopy?
Right. Last time we were starting, you were answering the big plus of a randomized trial is that interpretation is easier.
Yeah.
So interpretation is, of course, more difficult with an observational trial, but I could say it could be complete.
Yeah.
So you have all the cases.
Absolutely.
No selection bias.
I agree.
In the ideal world.
Yeah, absolutely.
But the ideal world is far away. So how much what could we do? I mean, it depends on the the medical system. How could we do to have a perfect routine documentation system? And what about informed consent?
So it's the same as we talked about when we ended our talk, that we need to have systems in place. So we need to rely on the systems. And one way of collecting data is to, let's say, have not as necessarily standardized patient's chart, but at least patient's charts that easily read. But that again requires that you and I classify things in the same way. So once we improve our stratification system, that we agree that this is the way we are diagnosing or classifying this tumor or whatever it is, that's one of the things that we need to have in place. And that needs to just be collected in the patient's charts. And then this data could go up to a research database. Let's say you wanted to do a study and you needed information on treatment or on classification of tumors. That needed to go up into that system. And in addition to that, we need, I think, also data on patient data not related to the medical procedure, but who that person is. Because as medical doctors, we've seen it. I mean, we have seen, and sometimes you have, a gut feeling that this is not going to go well. And of course, you might be wrong, but at least sometimes you feel like you're right.
Attitude, approach, depression, whatever. Yeah.
And these factors may influence, your outcome. So if we could capture, the more we could capture, the better. But then if that is very resource demanding, maybe it's not worthwhile. Maybe it's worthwhile to just look at the incidence rates in Germany by county. Maybe that's enough, or by 5-year age groups. You can't maybe say so much, but it will give you an impression. It will give you some sense of what's going on. And I think that's the way we should start, by collecting very easily available data, for example, of what we have in the cancer registries, which in Norway we've done since before the randomized trials started, which makes we get a lot of information on those simple things too. So that's one way to start. So we should, again, what we talked about in the randomized trials, we shouldn't throw the baby out with the water, bathing water. We shouldn't do the same here. So that's build stone on stone. I think that's the approach, to have good data on causes of death. And how do we have that? How good are you at finding the causes of death? We don't do any autopsies anymore. How are we going to have a good system for that? Maybe we should go back to doing more autopsies in order to understand what are people really dying from, in order to understand what is treatment, what's the effect of treatment. I don't know, but this is very simple, but then again, also
But still, the message is important. If you do observation, be at least as good in documentation as if you would do a randomized trial, right?
Yeah.
So not less, because otherwise you have to retrospectively try to guess and speculate and find out and whatever.
Yeah. Or you can be simpler. Very simple. Say, well, you know, we can't say anything about the causes here, but this is the trend we're seeing. We've been seeing this over years, for example.
That's right. But don't we want to know why?
Yeah, but that's then the next step. So that's how we get knowledge. You know, you start by looking at the big picture and then you narrow it in. And then the problem, I think, with humans and when we do research is that we get so caught up in our own ideas that we can't let them go. So because that's I think, one of the main criteria for being a good researcher is that you need to let your own thought system go, and it's very hard, and I'm sure none of us can completely do it, but always remind yourself that, hold on, is this correct? Am I thinking in the right direction now? So maybe then, so what I tell my PhD student that, and we do a mixture of randomized trials and observational studies in my research group. And the reason for that is I want to test the methods we use in observational studies in the randomized trials, because there I have the sort of the golden standard. So going back and forth between the two sets of experimental and observation, I think is good. And what I tell them is that the way you work is that you try to look up and see, you know, the sky and have the overview, and then you can go into details, but you need to get up again. And sometimes I have the sense that people go into more and more and more and more and more details, and without, you know, lifting their head and looking up and thinking, hold on, where are we at? So I think that's very crucial when you want to do observational studies, and then you can build.
It's a little bit like in these sophisticated endoscopic interventions where you work with a knife, you have to go back and see where you are.
That's a great picture.
At some stage,
yeah. And that's the same in research, really. This is what you're doing. Go down, it's okay, and lift yourself up. Because sometimes we're caught up in the details. That's how we are. I think a lot of medical doctors are. That's why we got into medical school, right?
Yeah. Here comes the question, because there's this hope that if we have, let's assume over the years we get a very good database.
Yeah.
There's this hope or this tendency nowadays to have a simulated randomized trial, which is called emulated trial, target trial.
Yeah.
What's your opinion on that? If it's complete, all patients. Maybe you can't include all of them, but at least,
Okay, so we're back to that X factor now again.
Yeah.
So since and we did an emulated trial with that kind of data, and we saw we couldn't, you know, match the randomized trial. So
Because?
That's the X factor. That's the thing. We don't know what captures. We can't, with all the best available data in the world, capture what that difference is between those who did not want to attend screening and those who were in the control group who did not have any factors. And we did all kinds of matching.
Screening maybe is especially difficult.
No, I think it's the same.
But if it's an interventional treatment and you have data of everybody, then I think if that's valid, that's my theory, the outcome would be maybe similar in different databases. So have we enough
I don't know.
enough evaluated the emulated trials, or is it new and we don't know?
So I think emulation is a good way, because you think, how would we set up a randomized trial? So I think that's a very good starting point. Whether they will succeed or not, I'm not so sure. Now it's modern to say that this is the way we're doing it. And everybody's saying that, well, just as long as we have all the data in the world, this is going to solve it. I do not believe in that.
Big data solves everything.
Yeah, I do not believe in that. And this is a belief again. And that comes back to the X factor that I was explaining a little bit earlier. There's so many things we can't really know, and we don't really know what matters. So it's a good start, I think. But I again, try to do smaller valid clinical trials. Let's base our medical treatment on that.
On the other hand, we have these big questions like early cancer. Can we do it endoscopically, or have we still to do it surgically? And that's exceedingly difficult to randomize patients. So
but then again, then we need, so I had a discussion once with a friend, and he didn't believe in randomized trial, and he said, well, when you jump out of a plane without a parachute, you know, it's that kind of discussion.
No, it's not that I don't believe.
No, I'm just gonna, I understand that.
Parachute.
So also in medicine, there are many things we don't need randomized trials. I mean, if, let's say you have the old-fashioned surgery, and then you have a new procedure endoscopically, and you have a patient who is 75 years old. Do you need to do a randomized trial, or could you just think that, a person is going to live maybe 10 more years, can walk right after, don't have to be lying in bed for 14 days, no eating, you know. So a lot of medicine is based on experience, and we don't, I am not in favor of doing randomized trials on everything. You need to use your brain.
Now it gets interesting.
To,
So how do we tackle that question? So we have endoscopic resection, rectal, esophagus, and what's a good study to convince whomever to get to a good journal for this organ-preserving therapy? Does it have to be randomized, because otherwise you'd never get into a big journal?
No, again, it depends. I think you need to be, if you have, okay, so we start with your observation. You see that, maybe I can help this patient by doing this or that. And then you know, curiosity, and you wonder, and you think, maybe I can do another, maybe, you know, looking at the gallbladder, whatever, looking at, you know, and then you think, I do have, you know, or you talk to a colleague who has a new instrument or whatever. Then you need to sit down and discuss, is this something that is just really technicalities? It's not going to change it? Or when we moved from open surgery to laparoscopic surgery, it was a no-brainer. Do you need to do big randomized trials for that?
There wasn't any for lap colon.
And I'm not sure you need it, because next day you saw, this patient was open surgery. He was admitted to the intensive care unit, and then he was there for several days, and then he didn't eat and you have the whole, you know, the whole trajectory of what happened. And then you had the, you know, the laparoscopic surgery, and you saw that, he's out of bed this afternoon.
But we are talking about oncology, and if you don't carefully observe those cases, they might have later recurrences. So the price you pay is not clear within the first, 6 weeks. Yeah?
That's why I made an easy example of the 75-year-old. So you caught me there. Of course, the more we do, the more we think of the long-term the short-term and long-term consequences. If there are long-term consequences, let's say that person wasn't 75, that person was 65 or even younger, 50 maybe. Of course, then that's harder. Then we need to discuss, is it worth setting up a randomized trial? And what should the outcome be?
Or possible.
Is it worth it? Is it possible? What should the outcome be? Because if you remove some precancer lesion, it's going to take 10 to 15 to 20 years before you get the anticipated effect on incidence, and maybe another 10 on mortality. And then you need to sit down and discuss. There is no quick answer to this. I think that the whole idea is to sit down and discuss what is the best option here. Can we live with that we don't know which one is better, the open surgery or closed? Is it okay enough? Or is this something we need to randomize?
And there's no way with a good observational study with both arms, you know, there are different practices in different areas, so you just observe and then try to compare
There's always other options.
Okay, I sense that your enthusiasm for this simulated randomized trial is limited. But if it's not possible to randomize, you would accept it, that we at least have these two groups, and I
think that's a very clever way of doing observational studies. So I don't dismiss it completely. I am just curious, how much better is it than the old models or old statistics and old ways of thinking epidemiology? And I might be wrong. I said once that this is the emperor's new clothes, but I might be wrong, and it might be too early. It may be that I don't know much about it, but I think the enthusiasm around it, I'm a little bit more skeptical. But I think one of the major advantages is thinking, how would we do this if it was a randomized trials? Because one of the disadvantages with the randomized trials is that not everybody completes their treatment, or not everybody, do what you like them to do. So you have, as you're probably familiar with, intention to treat analysis and the per protocol analysis. And doing an emulated trial could be more or less a per protocol analysis, assuming 100% attendance or adherence to medication and stuff like that, which I think is very interesting. And then mixing the methods here, I think it's a big advantage. The way they've set it up, I see a lot of advantages in that sense.
Or maybe you go one step back and don't fiddle around and try to simulate a randomized trial, and you say, here I have this big cohort well documented with endoscopy, here I have this big cohort well documented with surgery, and look at them and what fits better for your patient.
And we should do that. We should do that. That's the one thing I think we've been not. And I think this is, again, based on the system that we have set around us, is that we should have control over what's going on with our patients, both the long-term and the short-term consequences. We have more knowledge about the short-term consequences, not the long-term consequences. I think we as medical doctors, we should also be aware of that.
Okay, so I get a better understanding. I think we learned a lot about observational studies, how difficult they are, but we shouldn't be discouraged because both are complementary.
Yes.
And I think the message is also that not everything needs a randomized trial.
Absolutely.
For different reasons.
Yeah.
Finally, a short word or verdict: retrospective studies. There's so many in endoscopy. Just forget them. What's your advice to a medical student?
Don't forget. No, I think so. The problems with retrospective studies is really that in order to do them well, we need to do them in a retrospective way, in a sense that we go back to patients' charts, what was written at that time, and then they are in a sense prospective, because you get data at the time when you wrote it. So in the old days, we said that retrospective studies, that was studies that you had to recall something. And then you have all kinds of biases, which is very hard. But when you go back to the patient's chart, so let's say you in June 1980 wrote something, and you go back and get that and collect that data, it is retrospective collection of data, but it's still prospectively data. If you understand what I mean.
If you find what you want to.
Exactly.
Otherwise, if there's a big hole, then.
Then it's then you get less information, really. But so for me, it doesn't matter if it matters when you have to remember what was done. But if you can get the exact data, it doesn't matter when you collect it after the fact or at the time. But it's easier if you collect it at the time in a standardized database, and you decide, I want to have these 3 factors registered every day, every time.
Well, in that sense, strictly speaking, if you have a very well-maintained prospective observational registry, then any analysis at a later point is kind of retrospective, right?
Yeah. Absolutely. Always. Yeah. And there's one thing that I want to say about data and data collection, because my impression is that we are very good at collecting data who has anything to do with costs or economy, but not so much. So a lot of the registered we have in Norway is really based on reimbursement systems. And I think why, for me, I understand that economy plays a role, but for me as a medical doctor, I'm really more interested in the patients. How are you doing? What am I doing to you? Am I helping you, or am I just making it worse for you?
And not how much money am I spending for you.
And but the system is based on that thinking. And I think we should influence the system, say, well, you could use both, but you need to collect better data. And I think that's one of the things we could improve and make much better observational studies.
That's a wonderful conclusion. I couldn't agree more.
No.
Thank you so much, Mette. Thank you, and thank you for listening and viewing.